going to go ahead and answer some questions, and I'll call up any of the docs or therapists or interdisciplinary care people that are still here to come on up here and help me out of this really amazing stack of questions, and we're going to try to answer as many questions as we can for you while you're eating your lunch. And so hopefully this will help you to digest some of that food and some of the knowledge. So question number one, there are no African Americans here today. Is it not that it's just as prevalent in that group? It's a great question, and let me just start by saying that there have been multiple studies of African Americans and Parkinson's disease, and there used to be a notion that it's less prevalent in the African American population, but recent studies are beginning to point to the fact that it's not so much that it's not as prevalent, but it's that the different demographics, social demographics, ethnic demographics, and other things are keeping African Americans out of our clinics, and that we need to do a better job of connecting with that community, because there are probably just as many African Americans with Parkinson's disease that need care as well. And there's lots of reasons why these people are not receiving care. So there is a nice program here in town that we're working with called Health Street that goes straight out to the communities to help these people, many of whom have Parkinson's disease. So next question. We've heard a lot of therapy, upcoming therapies for Parkinson's disease. What's happening for progressive supranuclear palsy? For those of you that don't know, this is a syndrome. The most famous person to have PSP was named Dudley Moore. He was a tremendous pianist, starred in many movies, including the movie series Arthur. This is a form of Parkinson that has less of a response to dopamine, although there are several features and several subsyndromes that do respond to dopamine. At the moment, there is not as good of therapy available for these folks as with Parkinson, but there are several drug and behavioral trials going on across the United States, but nothing that has been incredibly breaking. But we're watching that, and we have a clinic here that's run by Dr. Farnham, who was here this morning, that does atypical Parkinson's disease. And so if anybody's interested in that, we can address that. So the next question is, restless leg syndrome has increased significantly. And when we got off Klonopin, because Klonopin was giving side effects, we started trying another medicine called Horizont, Horizant. What's the downside of this drug, Horizont? I have personally not used Horizont before. So we think it could be a long-acting version of an anticonvulsant, maybe related to gabapentin in that family. None of our panel has experience with that. We do know that Dr. Hess has said it's a long-acting version of gabapentin, which is an old seizure medicine that doesn't work very well for seizures but works for pain. There's also a couple of studies showing it can be useful in restless legs. If it's like the short-acting version of gabapentin, it doesn't have any side effects. Some people it makes a little bit sleepy, but one of the benefits of gabapentin is it's usually fairly safe without many side effects. So the next question is why do my feet cramp in the morning with Parkinson? I'm going to pass it over to Chris Hess to answer that question. Why do my feet cramp in the morning with Parkinson?
So one of the symptoms that develop in patients who have Parkinson's disease is dystonia. And Dr. Malati talked a little bit about dystonia today as one of the symptoms that develop in Parkinson's disease. Dystonia can happen at various different times during the course of one's treatment. The most common time for dystonia to happen, for this cramping to happen in the feet, is when you've been off medications for a long period of time. It's called off dystonia. So very often when patients have been off their medication all night long, even if they're on a long-acting medication, when they wake up in the morning, that's when their cramping will be worse in the feet. So if patients are not on a long-acting Cinnamon or another medication that's designed to be longer acting at night, some Sometimes if an overnight dose of long-acting is not helpful, you can take an additional dose during the night if you have to. And other times, foot cramping can actually be addressed with botulinum toxin. So the same Botox that you hear that the celebrities use on their faces. Long before celebrities were using it to reduce their wrinkle lines, movement disorders neurologists were using Botox and botulinum toxin to reduce some of the abnormal muscle tone that's associated with Parkinson's disease and other movement disorders. So if a person has a lot of foot cramping that's been refractory to medications, to some of the changes that I had mentioned that would be tried first, then sometimes botulinum toxin of the feet can be very effective in reducing cramping. And if you're having it put done by someone who's had some experience with it, very often you can reduce the cramping without causing any additional problems in gait or in walking.
The next question is what will be the score of the Gator game tonight against Connecticut? Could you tell me before I have to place my bet later in Las Vegas? I think that was Amanda. Okay, next question. Could I take Cinnamon every other day and it be effective therapy, or is there a cumulative effect that would be lost? One thing you should know about Cinnamon, that's dopamine replacement therapy, is that this is an extremely short half-life drug on the scale of hours. Okay, so it disappears very quickly, much quicker than most of the other drugs you take for like high blood pressure and things in your life. We don't recommend that you skip dosages, much less skip days without dosages. If you stop Cinnamon abruptly, there can be a very bad reaction called neuroleptic malignant syndrome. It usually takes more than a day to appear, but we never stop it abruptly, and we never do every other day dosages. So I think that's a good question. So what is the treatment for REM sleep behavioral disorder?
So we talked about that next door. REM sleep, rapid eye movement sleep, is when you're dreaming, and REM sleep behavior disorder is a problem where you don't have paralysis of your muscles while you're dreaming. So people kick and punch and move and fall out of bed, talk in their sleep, and it doesn't only disrupt their bed partner's sleep, it also makes them feel tired the next day because they're not getting good rest. And the most common treatment is clonazepam. It's a medicine in a family called benzodiazepines, and it can really be very helpful for this condition. Other times we have to look at what medicine the person is taking, and we may need to make medicine adjustments. I'll go ahead and answer this one. It also is something we talked about next door. What is the very first symptom reported to people of Parkinson's disease? Is it a lack of arm swing or excessive salivation? And it's different for each person. But studies have looked at what were some of the very first clues that might be related to a diagnosis of Parkinson's disease. And some of the very first clues may be the loss of a sense of smell, which also can influence ability to taste things, loss of smell, restless leg syndrome or this discomfort in the legs, or the REM sleep behavior disorder. Sometimes people do report their arm swing, and sometimes people do report a change in their facial expression or their handwriting. Those are common symptoms. Constipation. Constipation is another one that sometimes can be present long before. And the other thing that goes with that question was, how does early diagnosis extend your life compared to later diagnosis? And what we know is the earlier you get on appropriate treatment, the more likely it is you'll stay active and be involved and be physically and socially active. And those are the things that probably extend your life the most. So getting on the right regimen when it's necessary is probably the best thing you can do.
Okay. B, 27. I, 42. Oh, sorry. All right, next question will be Dr. Hess.
This question is, I'm a 62-year-old male, and I have concerns in burning out of my medication. So there's a couple of things this could be referring to. What normally happens in patients who have Parkinson's disease when they first get diagnosed They'll get treated with medication, and eventually they get started on Cinemet. The Cinemet, whether they take the medicine on time or not on time, it seems to work all the time. It works throughout the day, and they don't really have to worry about it. They're a little bit late with the dose. They tend to get benefit that's consistent throughout the day, and this lasts a couple of years, and then over time they'll notice, well, boy, if I'm late with my dose, I really start to feel it now. And then they start to pay attention to their dosing schedule, and they really make sure that they're on the clock. And then after a little bit more time, they'll notice, well, I'm not quite making it to that next dose. I'm actually having my symptoms come back earlier. So what people will experience, and this is one of the types of what can be called burning out, people's doses will often have to be moved together to get rid of this turning off period that can happen at the tail end of doses. So one of the most important things that your neurologist can do for you, if you're having an effective medication that's wearing off before your next dose, is to move your doses closer together or to make other medication changes, with the goal of being to try to prevent that medication benefit from burning out before the next dosing administration. So I'm not exactly sure what in the term burning out, what the question is referring to. Other people sometimes question. There's a lot of information on the internet about Cinemet. People sometimes can be very nervous about Cinemet because they say, I've read on the internet that after a while Cinemet stops working. So they're worried about taking Cinemet, worried about starting Cinemet. We know that Cinemet always works. It's never a question of the medicine not working. What can happen after a while is, first of all, people get worse every year because it's a neurodegenerative disease. And even if you're getting worse at a rapid rate or at a slow rate, people do tend to get a little bit worse over time, or to some degree worse over time. So always down the line, it's going to feel like the medicines are not working the way they used to, because your disease is always, with time, is going to change. The other issue that can sometimes come about is, especially if you're on Cinemet, the time that you have, as I mentioned earlier, of the medicine lasting reduces, and then you get the extra problems that are associated with the medication. You get the dyskinesias, the extra movements that people have seen Michael J. Fox on TV. He looks like he's moving all over the place, things that you might not do if you don't have dyskinesias. So these are complications that develop because of the medication changes. It's not specifically a burning out of medicine. How long and often should one stretch? So, and what type of stretching is good? The most important thing with regard to stretching is that you're doing exercises that stretch and strengthen both the upper limbs and the lower limbs, and that you're doing an exercise that involves a full range of motion. The more stretching and strengthening that you do, it doesn't have to be high impact, the better. So there's really no limit. It's just based on the individual and what they can tolerate. The last part of the question is, can Parkinson's disease be diagnosed by a blood test? So one of the talks that we had next door was whether or not Parkinson's disease can be diagnosed by a neuroimaging test. So it's reasonable that people would think, is it possible that at this point Parkinson's disease can be diagnosed with a blood test? So right now there is no blood test that can diagnose Parkinson's disease. People are looking at what's called biomarkers, things that can be indicators of the presence of the disease and possibly of the presence of the disease before it even develops any symptoms. Right now, there's no current blood test that can diagnose Parkinson's reliably.
Okay, I've got a whole bunch here. I'm going to answer them in rapid fire. The first is about any relationship between iron and neurodegeneration in cells in the brain and any new drugs. There's no new drugs that I'm aware of with iron, although iron is very important in the degenerative process and in multiple diseases, not just Parkinson's disease. I'm asked to comment on the relationship between melanoma and Parkinson's disease, and it actually turns out that there's a higher incidence of melanoma in patients with Parkinson's, and so it's important that you, especially living in the state of Florida, which has a higher incidence of melanoma in general, it's very important that you visit your dermatologist at least once a year with Parkinson's disease and be checked for melanomas. There is no relationship between Parkinson medications, Cinemet dopamine replacement agonists, MAOB inhibitors, any medication, and melanoma. So the dopamine in those medications has not been found to be causal in any of the melanomas. Would you comment on any relationship between Ashkenazi Jews, Eastern European, and Parkinson's disease? The most common group, the largest group of patients who have Parkinson's disease in genetic studies are Ashkenazi Jews. The most common genetic defect in the Ashkenazi population is the LRRK2 mutation. Okay, and so that's important to know that Ashkenazi Jews have a high burden of Parkinson's disease and large family histories. Many studies are going on just that area across the world. What exactly is a center of excellence? Well, that's a long question, but I'll give you a short answer to a long question. There's this application that you can make to organizations like National Parkinson, and they have a long list of requirements that you have to meet in terms of care, in terms of care team, interdisciplinary care, research, outreach, education, access for patients, and having independent research trials on things that are brought to light by researchers at individual institutions. And it's a mix of those things, plus a peer review visit where people actually show up and make sure that you have what you say you're going to have to get a center of excellence. The biggest center of excellence program is sponsored by National Parkinson Foundation. It has about 40 centers. There's a couple of centers of excellence that are funded by the Parkinson Disease Foundation, one in Columbia, one at Rush in Chicago, one in Columbia in New York. There's a center of excellence program by the National Institutes of Health called the UDAL, one named after Morris K. Udall centers, and those are research-only centers, very basic research. And there is a center of excellence program, 6 centers of excellence in the VA called Podrix. They all require applications. And finally, is marijuana useful for any Parkinson's symptoms, and will you be giving marijuana out free today at the symposium? Well, I'm happy to say there will be a man in the parking lot that you can visit on your way out. And you don't have to introduce yourself or tell them anything about you. He will provide you with some marijuana. Now the question is that if you take marijuana from this man, will it help your Parkinson's disease? And it is a question that is asked frequently, and it has been laughed off by many people, but personally I don't laugh off the relationship between cannabinoid receptors, where marijuana operates in the brain, and diseases like Parkinson's and other diseases like Tourette that share some of this same inner workings and science behind the disease. It turns out that there are receptors that seem to be helped in animal models, and we've heard some human reports by these types of drugs. There have been several studies now on Parkinson's disease, carefully done studies that have not documented any benefit, but does that mean that there isn't any benefit? No, it doesn't mean that there isn't. And there may indeed turn out to be a relationship between these cannabinoid receptors and Parkinson's. We strongly discourage smoking marijuana, for anybody, because of the health effects of smoking it are bad for your lungs. It's probably, not as unsafe as many doctors will have you believe to take it, but if you do take it, we often will tell you or advise you to, have Amanda Eilers, the Parkinson coordinator, wrap it up in a nice cookie or brownie or something. You will see multiple studies coming out over the next 36 months on marijuana and Parkinson's, so hopefully we'll have more answers for you. We also know that anything that calms you down and calms the anxiety also calms Parkinsonian symptoms, and so it may be also a very strong anxiolytic. So we don't dismiss marijuana, but be careful of the guy in the parking lot.
Okay, this question was Mirapex disapproved and has it resumed? Not to our knowledge, there's been no disruption. I think maybe this question meant to ask about Nupro, I'm going to guess. Mirapex is available on the market. It comes in a short-acting and a long-acting form. And I think this person probably meant to ask about Nupro, the patch. That was taken off the market for a period of time. They're both medicines in the family called dopamine agonists. They both work for Parkinson's and for restless leg syndrome. The Nupro patch was taken off the market for a while because of a problem with the delivery. It was the medicine was crystallizing on the patch and not administering properly. It wasn't a dangerous issue, it was just that it wasn't delivering well. And that was in the US, not in a European plant. So it was taken off, it was reformatted, and it came back, so it's back on the market and available. approval. These other questions are,
So just, there's another dopamine agonist in case this question got confused. There's a dopamine agonist that comes in a patch formulation called rotigotine. Yeah. And so, you know, you should know that particular agonist did go through 2 more years of FDA testing working back. So it is safe. So if you're worried about safety and it worked for you before, talk to your doc. It's back. Safe.
so the other questions are, is there a diagnosis for multiple system atrophy? And is there a diagnosis for a test for progressive supranuclear palsy and other Parkinson's syndromes? So we talked about that the symptoms of Parkinson's, the tremor, the stiffness, the slowness, the gait changes, they can be caused by Parkinson's or some other conditions that look real similar on the outside. Even though we looked at the brain under a microscope, it's actually a different condition. And those conditions are several, and the ones that the person asked about include multiple system atrophy and progressive supranuclear palsy. There's not a specific test that will tell us which one you have if you have the symptoms that can be confused for any of those. In fact, tests like Dr. Hess talked about, the DAT scan will be abnormal, whether it's Parkinson's or MSA, multiple system atrophy, or PSP, progressive supranuclear palsy. What distinguishes them is the rate of progression of symptoms and how well it responds to the medicines that are designed for Parkinson's. So if you respond very well to the medicine and the symptoms change slowly and gradually, that's more common for Parkinson's. If the symptoms progress very quickly and the medicine only helps a little bit, then it's more likely it's one of the others. People with multiple system atrophy tend to have more troubles with what we call the autonomic nervous system. Part of our nervous system that regulates things like our blood pressure, our intestinal movements, temperature regulation. Men may experience erectile dysfunction at an earlier age. So if we see a lot of that early on, we may wonder about one of those conditions, even though those things may occur in Parkinson's. People with progressive supranuclear palsy tend to have rapid progression of gait problems and falling within the first 2 or 3 years of symptoms, which is less likely in Parkinson's. They may develop eye movement problems. So it's more what we see. And the question also is, what are the treatments for those? And the treatments are the same. We treat the symptoms with similar medicines to what we use in Parkinson's. At this point in time, there aren't medicines that are specifically approved just for those conditions.
Question here. What are the medications to take for dementia? So, if anyone was in Dr. Bauer's talk next door earlier today, they heard a little bit about dementia and cognitive problems that develop in Parkinson's disease. There are medications that I'll talk about. Probably the biggest thing that you can do is making sure that you're staying active, making sure that you're staying cognitively involved in things. With regard to medications, when someone has dementia or when someone has cognitive problems, whether it's specifically dementia memory problems or whether it's hallucinations, which is sort of like dementia, one of the most important things that you can do is look at the medication regimen that the person is on and see if there are any medications that are causing more problems than they're helping. So anytime you have a patient who has cognitive impairment, who has Parkinson's disease, before you consider adding another medication, you first want to look at the medications to see if there's medicine that might be causing a problem, because sometimes just by simplifying the medication regimen, you can make improvements. Beyond that, there are medications. There's medications that are approved for dementia related to Parkinson's disease. There's donepezil, there's sigmine. These medications are administered once to twice a day. The benefits that are seen with them are relatively modest, although on the individual basis, although in large studies they are statistically significant. I've not had a lot of patients tell me that they notice dramatic differences. I've had some patients notice when you take them away. But medication-wise, there's not a dramatic benefit that we get from the medicines that are available to people who have dementia-related to Parkinson's disease.
So, how do you qualify for drug testing and for clinical trials? Well, all you need to do is, if you're a current patient center, you just need to simply ask for any of the coordinators. They're all cross-trained. We have 8 coordinators led by Stacey Merrick, colleagues. Several of them are here today. I mean, Iris is actually a coordinator, as is So you just ask to visit one of the coordinators, and we can review all the trials that are going on in the center, and whether you would qualify for any one of them. You can also shoot them an email, and bug that. They never, I can speak for them and tell you that they never mind being bugged about being asked. And it's one of the secrets, I think, to care is making sure that you're continuously asking your doc and your team, not just your doctor, but other team members who may also have trials or things you can qualify for, about what's new in Parkinson. That also gets the team members excited. There was one question that wasn't asked that I've been stressing to the groups that I talk to, and that's that exercise is good, but if you are overdoing it, that can be bad. Okay, so you need to realize that everything needs to be modulated against each patient, and so you read these papers, particularly forced exercise or forced exercise with a bicycle, and they say get up to this amount of RPM or run at this speed or do X exercise with this amount of intensity. We actually don't know the intensity levels, and if you are very fatigued the next day after doing this, then you're doing too much. Okay, you should be feeling better, not worse. And so you need to work your way up. And for some people, they're never going to reach the levels that are published in some of these studies that are coming out. And so as we interpret exercise, we interpret it to be good, but don't try to be an Olympic athlete. And if you're feeling bad after long amounts of exercise, you'll need to back off on how much you're giving you. We do just like medication doses.
Okay, so thank you so much for coming here, for participating. We'll be around if you have a few more questions. I'd like to especially thank Amanda Eilers, our coordinator. Organizing this for all of us and arranging this lovely event, but Amanda just got engaged this week. Congratulate her. Thanks so much. We hope you'll come back next year. If you have ideas of talks you'd like us to repeat or different things you didn't hear about, you want us to talk about, we had a great suggestion that caregivers and life partners with people are wanting something specifically for them. Any other ideas, please let us know. Let anyone, Amanda know, let us know, and we'll be happy to try to incorporate it the next time. Thanks. Yes, Steve.
What would we need to electronic communication so you don't have to go out to the instrument and find our meetings and stuff? So we can have people come together, maybe a rec center or something out, communicate with you, what would we have to add?
Are you asking how you might know what programs are available if you want to come here?
For us to be able to communicate with you directly with us here.
Well, anyone who's a patient in our center has access to computer communication through something called MyChart. Anybody who sees us can have Amanda's email, our emails, and can just communicate with us. We keep a website that's updated with programs that are going on in the area and all the programs at the center. And so those are just some of the ways. But if you have specific ideas, come grab us and let us know what you're looking for. Well, what we do have is the National Parkinson Foundation does webinars, and they monthly. Every month they do a webinar on a topic of interest, and they put it online. You don't have to travel anywhere. You can watch it in your living room. You can watch it anywhere you want.